All right, folks, it is 6 p.m. Thank you so much for joining our rural EMS education session. We will get started. I will let Dr. Christy Hawley introduce herself, but we are very lucky to have her here, one of our awesome trauma surgeons, talking about pre-hospital trauma care. Dr. Hawley, take it away.
Thank you so much for having me. My name is Christy Hawley. I'm faculty at the university. I did my 2-year trauma and critical care fellowship at the University of Maryland Shock Trauma, where I got a lot of exposure to penetrating trauma. I've been out in Colorado now I'm coming up on my 2nd year as faculty here. I am the associate program director for our trauma fellowship. We have a 2-year program and have 2 years, 2 fellows per year. So you'll see 4 of us around kind of with them. And then additionally, I'm actually very involved in our resident education around robotic surgery and very passionate about the use of minimally invasive surgery in emergency general surgery and even some stable trauma patients. So I tried to tailor this talk to rural trauma care. So I'm going to go over some studies that just give a really nice background, I think, of the issues that are likely facing many of you and the participants on this call. Additionally, I'm going to go through kind of some of the hot topics that I think are really relevant in pre-hospital care. And I tried to find the most relevant studies in the last probably 5 years to make sure that we're talking about the most recent evidence. So I do not have any financial disclosures to make. So here are our objectives for this talk. I'm going to try to stick to a little bit over an hour. Looks like we've got an hour and a half, so I'll leave a lot of time for questions. So we're going to try to recognize disparities and access challenges in rural pre-hospital trauma care, understand the use of the shock index for rural triage and resuscitation, understand the role of teletrauma in improving trauma access, identify effective methods for hemorrhage control and pelvic fracture, including mechanical stabilization, evaluate the role of whole blood, plasma, and balanced transfusion practices in managing hemorrhagic shock in trauma patients, and assess the safety and equity considerations of whole blood use in pregnant trauma patients. We'll also touch on TXA. And then explore the impact of pre-hospital interventions such as tourniquets, TXA on survival and morbidity in trauma cases. So I'm trying to mix it up a little bit. I won't try to dwell on any one topic way too much. All right, so we'll start with background on rural trauma care. So this was a study, this came out in 2017, and this is in Injury, which is one of our trauma journals, and was assessing disparities in access to trauma care in the United States. And so this review found that there were 29.7 million Americans that lack 60-minute access to level 1 and level 2 trauma care. Which is really where these principles of ATLS kind of come in place to make sure that we are stabilizing patients and trying to get them to definitive care, which most of the time in trauma, that is meaning the supervision of a general surgeon who's trained in trauma care and can kind of help coordinate the care of multiple specialty surgeons. So often we're seeing transfers to CU from even other level 1 facilities. I'll give you examples, complex ophthalmology, skull-based fractures that maybe an ENT surgeon in the community is not comfortable managing, multi-trauma with a head injury. And so even all level 1s are not even made equal, unfortunately. And so even if you have level 1 trauma care, it still doesn't mean that you're going to have definitive care. So it's just something to keep in mind as well. So rurality was found to be strongly associated with poor access, lower income, higher uninsurance, more Medicare, Medicaid eligibility predict reduced access. Higher income and urban location increase the odds of trauma center access. I can tell you where I trained in Baltimore. A lot of health disparities there, but also very kind of higher income part of the city. And we had 2 major level 1 trauma centers within about a mile and a half of each other. Black, non-white, Hispanic, and foreign-born populations are more likely to have access overall. And this is mostly thanks to a lot of the research done in the 80s and 90s, and not just research, but advocacy really through the American College of Surgeons by orthopedic and general trauma surgeons to advocate for the designation of level one trauma centers and ensuring that they're actually placed in areas that need them. But when we're talking about this data, we're mostly talking about large urban cities. There was a subgroup analysis revealed decreased access for Hispanic and foreign-born in minor cities, and urban poverty was linked to lower trauma access despite proximity to centers. And so that's a curious one. Structural healthcare components and payer mix influence trauma system placement. And then all of these findings highlight the need for local scalable solutions to improve trauma access. So this is always a hot topic when they're thinking about opening a new level one center. There's always lots of debate on where it should be, how it should be funded. Is it repetitive, or is it providing some new service to the patients in that community? One area you can really look at if you want to read about this topic, you can look at the Cook County versus University of Chicago debate. University of Chicago actually came into an area that was most likely very underserved. However, it was very controversial, um, probably for two reasons. One, it's very expensive, and not always a money maker for a big healthcare system and university to absorb a level one trauma center. The other reason being that it actually took a lot of patients away from Cook County. And so I've even heard from residents who used to rotate at Cook County that the volume is so low that they no longer actually rotate there as general surgery residents because there's just not enough cases for them to see. So all of these decisions are really, really important to the public health and to our trainees, which is extremely important because hopefully one day they're going to be taking over my job. This is another paper looking at the contribution of rural non-trauma hospitals to trauma care in the annals of surgery. And so over half of injured rural residents are initially treated at rural non-trauma centers. I'm always extremely impressed when we get phone calls for requests for transfer of what these small non-trauma designated centers are able to do with the help of, their own experience and really being dedicated to those ATLS principles that we learn, in emergency medicine and surgery to make sure that these patients are stable for transfer. And so rural non-trauma centers manage 77.5% of visits definitively, including 2 and 5 severe injuries. And urban trauma centers saw most severe cases and had the highest procedure rates and costs. The ED and inpatient mortality rates were low across all hospital types. And they found that the rural non-trauma centers were often excluded from trauma registries and performance improvement systems. What you may not realize is that to be a trauma designated center, it actually requires a lot of resources from the hospital. And what I mean by that is really human resources. So for every X amount of patients that we see, we have to have one trauma registrar. As one of the faculty members as part of our group, we meet at least 2 to 3 times a month to actually go through our quality metrics. And so we actually have a whole team of mostly retired nurses who are going through this, creating and validating our trauma registry, and then working with the surgeons to really increase um, our quality metrics and our quality programs. And so they inspire a lot of the work that we do. So this is really important that this is not a benefit that a lot of rural centers are going to have, unfortunately, just because of the financial backing that's kind of required. And if the American College of Surgeons isn't requiring it necessarily, it's probably not going to happen. So closures of rural hospitals threaten trauma care access and continuity. Rural emergency hospital programs aim to preserve rural emergency care without inpatient services. And so these centers are really a critical and under-recognized component of our trauma systems. And so this paper in particular was really calling for policy support, collaboration, and inclusion of these rural centers into trauma system planning, really ensuring that they're part of the network. And I have to say, one of the big benefits of working for UC Health is the doc line, and really being able to connect all of these rural trauma centers to us and have almost immediate access to a trauma surgeon to help them decide, where does this patient need to be? Do they need to be transferred? And we can give as much support as we can to try to get them there as fast as possible. All right, this paper is another one looking specifically at rural trauma care. And so this is one of our most prestigious journals. This is the Journal of Trauma and Acute Care Surgery. I was excited to find this one because it's more current, 2023. It's a multi-center study that was done through I believe through EAST, which is one of our trauma organizations. And so they were looking at the pre-hospital shock index and whether or not it can predict outcomes after prolonged transport. So this multi-center study included 789 patients across 4 rural level 1 trauma centers. And so the shock index, which I'll talk a little bit about later, but it is effectively the heart rate over the systolic blood pressure. And then they talk about the delta shock index. And so this was evaluated at by EMS and at transfer and then at definitive care. And so this study found that the initial EMS shock index is going to predict the need for blood transfusion, ICU care, and operative intervention. This is a shock index is something I quickly kind of calculate in my head, just in the trauma bay when I've got a patient with an abnormal heart rate and systolic blood or systolic blood pressure to kind of think about how sick they are. So a increased delta shock index was strongly associated with increased odds of blood use, ICU stay, and surgery. Seeing patients with an elevated shock index or delta shock index were more likely to require urgent intervention. Transfer patients with a rising shock index from transfer to definitive care were at increased risk for mortality. So I think all of these findings are pretty intuitive, but I think it's really, really important that maybe we need to consider the use of shock index more into national field triage guidelines. And so, this is something that we're frequently using in the hospital. And this study really validated that this is something that we can use in the pre-hospital setting as well, to kind of gauge how sick a patient is, how quickly transfer should happen, and where might be the best place for definitive care. If somebody's got an elevated shock index, taking them to a place where it's going to take a surgeon an hour to get there might be a big problem. And so that might be a patient that you're probably considering air transport for. All right, there's this concept of ambulance deserts and inequalities in access to emergency medical services. And so this study was kind of looking at are injured patients at risk for delayed care in the pre-hospital system. So this study defines ambulance deserts as a census block group outside 25 minutes of an EMS response radius. And so 2.6% of the US population lives in an ambulance desert, including 8.9% of rural and 0.3% of urban residents. And these were found to be most prevalent in Alaska, Montana, Wyoming, Nevada, and Hawaii. I can tell you just looking from that list, we frequently get transfers from Montana and Wyoming at Anschutz. And so ambulance deserts in this study were correlated with a higher area deprivation index, indicating greater socioeconomic disadvantage. And EMS stations per capita negatively correlated with the area deprivation index, and there were fewer EMS units in more deprived areas. The Western Plains and West regions have high rural ambulance desert prevalence, 15.4% and 27.3%. And these deserts are really associated with higher mortality in trauma, cardiac, and motor vehicle collision patients. And so this is really going back to the concepts that really started the focus of ATLS, which is, just because you end up here in that kind of area as a trauma patient, We just need to make sure that we can do everything to try to prevent trauma deaths. All right, and then I believe this is the last one here. So this is a another one from JTAX Journal. This was in 2024, so another current one. This was a population-based study looking at 3,141 counties from 2017 to 2020. And they were looking at ground transport time to the nearest level 1 or level 3 trauma center. They identified 92,000 motor vehicle crashes, deaths, and they found that the median access time was 47 minutes, and the median MVC mortality is 12.5 deaths per 100,000 person years. Counties with greater than 60-minute access time had 1.36 times higher motor vehicle collision mortality versus less than 15 minutes. And so it's this dose-dependent increase in mortality with increasing access time. That's not a surprise to anyone on this phone call. And so again, once again, another call to improving access to trauma centers may reduce crash fatalities, and geospatial access to care is a key trauma system performance measure. And so a lot of us in the trauma community are getting really interested in geospatial studies. I'll give you an example of one I'm working on. I started noticing that several of our patients, there's two patients that we see quite commonly. One is falls at the airport down the escalator. The other one is being found down on Colfax, right outside the hospital. And so we're actually doing geospatial analysis, even in our area, trying to figure out like, is there something to do with that area? Why is it happening there? Are these people pedestrian struck? Is it more drug related? Why are they being found down and actually being categorized as a trauma patient? So, you can even do kind of more local geospatial studies. And so I think if anyone's really interested in rural care and rural trauma care, I think this is really the kind of evidence that people are going to need for big policy change is trying to show not only where are shortages, but even thinking about where would be a key area to actually have certain interventions that might be missing in the field. All right, I wanted to introduce this concept of teletrauma. This is something that I kind of got more familiar with, being in Baltimore, everybody's flown into Baltimore. We don't do a lot of teletrauma. We don't kind of use any kind of app or anything like that. And when I came here, I took a little bit of emergency burn call just to help out because they were short on some burn surgeons. And so I got to know the burn application, and it really got me thinking about using telecommunications to really kind of get a better sense of actually what's going on in our rural communities. So I can actually see, maybe they don't even have a CT scan yet, but maybe I can actually look at a deformity, or somebody can video in me, live so that I can actually see what's kind of going on in the trauma bay. So I think we have a lot of room here for growth, and I'm really excited to kind of see these papers come out. Um, so one is a review that I'll go over. The next is a policy kind of call for action. And then the last paper I'm going to discuss is based on a pediatric teletrauma program that's been pretty successful. So here, only 8.4% of EDs actually reported teletrauma use in 2020 versus 60.4% using other telehealth services. I'm sure you guys are very familiar with the other kind of telehealth services that we're using for, in the emergency department that you guys are probably much more familiar than I am, around stroke, around MI and the cath lab. Lots of really cool technologies there to make sure that we're bringing cardiac cath teams together, IR teams, all of this, and not really adopted much yet in the trauma community. But teletrauma is more common in rural areas, especially critical access and stroke-ready hospitals. There's significant state level variation, with some states showing as great as 60%, greater than 60%, others showing 0. Use seems to be associated with lower ED volume, rurality, and non-trauma center designation, right? And so that's really saying that this technology is filling a void, filling a need. Adoption between 2017 and 2020, which was studied in this paper, was driven really by critical access and basic stroke center status. Unfortunately, though, trauma is still lagging behind telestroke despite similar urgency and system design goals. I'm sure this has to do with, probably decreased creativity by the surgeons on how we can actually get involved in this. But I think I really am more of a proponent of trying to encourage our trauma community, especially in states like Colorado, to think creatively about this. So barriers seem to be lack of evidence, complex multidisciplinary trauma workflows, and limited national strategy. So it really does seem that this needs to come kind of from a higher up place, our trauma societies, any of the trauma groups through emergency medicine, to really kind of guide this effort. Um, there's a potential to improve rural trauma access, reduce unnecessary transfers, and enhance resuscitation. I can't tell you how many times we fly somebody in from another state, and we honestly really aren't doing much other than doing neuro checks and getting a repeat head CT, of which with our current protocols, depending on if it's a very small subdural hematoma, we're not even consulting a neurosurgeon. So this kind of concept of always needing a neurosurgeon for head trauma is not even necessarily true based on kind of more of the level one center data coming out of University of Arizona. It's called MBIG, which we now have built into our protocol actually at the university. So, further research is required in implementation, effectiveness, and policy development. And so we see this, which is fantastic. But one of the rural trauma committees actually made a statement within the Journal of the American College of Surgeons, which is a really, really popular journal for us as surgeons. And they basically made this a big call for national standards, multidisciplinary collaboration, toolkit development, and the goal is inclusive, equitable trauma systems and improve rural access and outcomes. So I was really excited to see that a couple of surgeons that I actually know pretty well have been working on this and published this in February of 2025. And so I think we're starting to see some slow movement around this and people starting to think creatively about this problem. And then finally, I just wanted to go over this one paper that talks about a pediatric teletrauma program. As you all are very aware, I am sure, if I gave a lecture on pediatric trauma, we'd find that there's even greater disparity to all types of pediatric care in rural communities. Not everybody has the beautiful children's hospital in their back door. So this is an example of a pediatric teletrauma program that was launched at a level one pediatric trauma center in 2019. And they expanded from 2 to 32 partnering hospitals across 5 states. They actually had 151 trauma consults within 4 years. Mostly were for a traumatic brain injury, 70% of them, and the median age of the patient was 8 years old. 63% of these consults actually avoided transfer, and only 3% needed late transfer. So that's the key. And that's how we get buy-in for these kind of systems within a large system like UC Health. It's a fact that we completely avoid an unnecessary transfer, that effectively we're not providing any intervention that couldn't have probably been done in the community. And so we're saving the overall healthcare system money. We are saving our personal healthcare system money by avoiding an unnecessary admission, and making sure we have a bed for, probably a non-trauma patient who needs an operation. Um, they found that transferred patients had higher TBI rate, but actually had a similar ISS and age. Partnering hospitals were up to 554 miles away with a median distance of 34 miles. The avoided transfer saved up to $4.3 million in transport and hospital charges. And so essentially they built this on protocols, daily virtual rounding, and monthly QI reviews. They felt that it improved family centered care, provider confidence, and regional coordination. And so this was a really, really great study. This was just published in 2024, showing that at least through one pilot across 5 states and 32 partnering hospitals, that this is scalable, cost effectiveness, and addresses rural trauma disparity. So I think, based on this teletrauma kind of new research and evidence and cost savings that are coming out, I'm really excited about where this is headed. All right, I'm going to break it up and kind of get off rural trauma. I'm going to talk about a topic that I think is really, really important, which is pelvic fracture, especially in the pre-hospital setting. So, pelvic ring injuries. So essentially, and most commonly, you're going to see exsanguinating hemorrhage can be associated with these kind of injuries. The most common is actually going to be internal iliac vessels and all of the feeding branches. And so it's usually a shearing force. And so it's actually, kind of like a slow venous bleed. And so, especially in the elderly, these are patients that can look okay and they can crash very quickly, even within the hospital. We've had deaths when people have elderly patients have come in and had a recognized pelvic fracture but had a binder on even, but unfortunately, by the time that everyone kind of recognized that they were now starting to briskly bleed, even with resuscitation, these can be really tricky. And I'll talk about some of the interventions that we can do in the operating room. But it can be a combination of osseous, venous, and arterial bleeding. And so saying that, you just send this patient to IR, that's not always really the answer. And so you kind of have to figure it out. So the treatment for you guys, we're really talking about mechanical stabilization. For me, I'm talking about probably both that and hemorrhage control. And something that's really important that we do in the trauma bay is we need to do a rectovaginal exam on these patients, especially when they're unstable, to kind of figure out what kind of bleeding is going on. We also don't want to miss, hemorrhage from, I've had a patient almost bleed to death from a missed vaginal injury, actually from a terrible pelvic fracture. We got all the bleeding controlled within the pelvis, but it was missed that she actually had pretty severe vaginal bleeding. And so there are things that we can do with our OBGYN colleagues to take care of that. This is the Young Burgess classification. I won't really spend too much time on this, but it's just kind of understanding that there's different injury patterns. So there's anterior posterior compression fractures. There's three different types. There's lateral compression fractures, again, three different types. And then there's vertical shear. And so, if you can imagine, the APC and the LC are often these fracture patterns that are really going to benefit from pelvic binder. This is something that even for a general surgeon who's trauma trained, trauma, all of this, we still will put a pelvic binder on anybody with blunt injury who's hypotensive and we don't understand what's going on. They get a pelvic binder before we can even shoot a film. And so I wouldn't worry too much about, what kind of, do they have shear or not? Do I need to put a binder on? The safest thing is to just put a binder on everybody. Um, the anterior posterior compression fractures often result in pretty bad hemodynamic instability due to the potential for significant blood loss from vascular injury. This is a lot of where the venous sacral plexus is, and so it's often disrupted. With the lateral compression fracture, you see this often in motor vehicle collisions that have side impact. And so these typically actually are going to present with less bleeding, but these are the ones that might involve bladder or urethral injuries. And then the vertical shear. These are the really bad problematic ones. So this is caused by vertical force. So fall from height, landing on one leg. And so you are essentially, these are very highly unstable fractures, often associated with significant soft tissue damage and neurovascular compromise. So, yeah, these are just the three kind of different fracture patterns that we think about when talking about classifying what kind of fracture it is. And this is the classification that the orthopedic surgeons use when thinking about how they're going to repair it and what they need to repair. All right, when we talk about mechanical stabilization, we talk about the pelvic binder. So T-pod is what I most commonly see patients coming in pre-hospital. This is also what we use in our emergency department when they come in if they don't already have a binder on. Some places use a sheet. I know there's been some protocols in our community where some EMS providers are actually being told that they need to be using a sheet. It looks pretty tricky to me to create. So bravo if you guys are excellent at this. I certainly have only had to do it one time. I think it did the job, but I much prefer personally the T-pod. And then there's this external fixation, which you can kind of see on the left side versus a C clamp, which is on the right side. These are very helpful, more in the obviously like in the inpatient setting. Examples of when we like to use these. If I've got a patient who's extremely unstable and they've got a really bad pelvic fracture that I'm aware of, but I also know that I'm going to be in the operating room for a while, working on their abdomen, maybe even working on their chest. This really clears the area completely of the binder. And so if you've got a femoral artery injury that you need to get to fix, or you're going to be working down in the pelvis, um, through the abdomen. That's really the point of these external fixation devices and C clamps. And so, we obviously rely on the orthopedic surgeons to place these, but this is kind of an attending to attending level discussion on whether we would really like to get the binder off and have them place them. People who are experienced with this can place these in the OR in about 15 minutes. It's really not a big deal, which is why I'm a huge fan of them. If I really need to be doing a lot of my general surgery and vascular surgery when they've also got an unstable pelvic fracture. All right, so this is an older paper. This is 2013, and this was really looking at does the application position of the pelvic binder affect stability of pelvic fractures? And they studied this, and based on their actual kind of like physics studies, they basically found that yes, it does. And so they advocate the placement of pelvic binder devices at the level of the greater trochanter for improved control of the fracture in an unstable pelvic injury. This may result in improved control of hemorrhage, better access to the abdomen, and greater patient comfort. And so this is a skill that I think for pre-hospital providers, I would love for you guys to actually come in and teach my residents how to actually place these properly. It's something that we continuously have to repeat. And so this really does make a big difference. If the pelvic binder is not placed well, it can be, I can pretty much look at it pretty quickly and realize that it's not in the proper position, and so we'll replace them. But this is something I've seen missed with people who don't have as much experience. Even trauma surgeons can miss this. You're focusing on other things and you don't notice that your pelvic binder is actually doing absolutely nothing. So the more that we can, one, put these on in the field, and two, put them on correctly, we will save lives. This was a comparison between external fixation versus a pelvic binder on unstable pelvic injury. So it was a cadaveric study. And so they found that while log rolling the patient and performing bed transfers, the pelvic binder conferred more stability in all planes of motion, although this didn't really reach any statistical significance. During elevation of the head of the bed, the teapot allowed less motion in the sagittal and coronal planes, but permitted equivalent motion in axial rotation. These were not statistically significant. And so they found that there were no significant differences in stability confirmed by an external fixator or a T-pod for unstable pelvic injuries. So the good news is that basically says that pelvic binders are fantastic devices. We should be using them, and that we don't need to stress about early conversion to internal fixation when a patient medical condition allows. So it puts less stress on pre-hospital providers. It puts less stress on inpatient providers like myself. We can keep that pelvic binder on while we're figuring out the rest of everything that's going on. And then we can see if we need to actually do external fixation, or if we can actually, even better yet, that the orthopedic surgeons can do a definitive operation and do an internal fixation. All right, when we talk about hemorrhage control and pelvic fractures, I just want to make sure you guys are aware of how we manage these on the inpatient side. So, most popularly, I'd say, is angiography and embolization. This is potentially less timely. We now, as level one trauma centers, have a deadline of 60 minutes, essentially, until, the way that we track it is I have a dot phrase in my note that says I called the IR attending at this time. And so between that initial phone call and them actually being in the operating room and doing their initial access to the vasculature, that needs to be less than 60 minutes. And so often they are either doing empiric bilateral internal pudendal artery embolization. And so even if it's not an arterial bleed, right? I said that most of these are sacral venous plexus bleeding. So the reason that they do this, like this kind of internal ligation, is to effectively decrease the amount of blood flow that's going to go into the venous system, to decrease the amount of bleeding. And then I've also seen some, skilled IR vascular attendings also do highly selective angioembolization. So when you actually see a blush, they can go to that area specifically and try to, especially if it's arterial, that's going to be the easiest thing to do. They can selectively angioembolize that. The big benefit there is that you decrease the risk of effectively causing pelvic ischemia and pelvic sepsis in the future. So we really appreciate highly selective angioembolization if necessary. Sometimes what happens has happened to me a couple times this year, while we are waiting for IR and they're definitely going to fall within that 60-minute window, the patient has increasing transfusion requirements. That is a really, really scary situation, and that is when we immediately go to the operating room. If everybody kind of has their own threshold, but if I've given 2 to 3 units and I'm feeling like the patient is not responsive, this is going to be my go-to, and I will make sure that I'm also in a room that is angio compatible. That means thinking about my OR table, whatever I'm using, so that I can pack and I can also wait for IR to get in there, and we can do kind of a combination case where they can also embolize. This is great for venous injury control. It can stop about 80% of bleeding. It is possible to get some arterial control. And then if it fails, like I said, you still got the angiography as a rescue. And then finally, we've also had to do this once this year on a very unstable patient. We have placed Reboa into the femoral artery. And blunt traumatic injury with known, in our case, known pelvic fracture where we had the binder on correctly, and they're hosing through product faster than we can even get them up to the OR. That is the time to go ahead and place a Reboa, but that is pretty rare. All right, and then if you're curious on how we do pelvic packing, we make a 6 to 8 centimeter midline incision. This goes from the pubic bone, the pubic symphysis, all the way up. And the pelvic hematoma is actually going to dissect that preperitoneal and perivesicular space. And so you place 3 laparotomy pads on each side of the bladder within that preperitoneal space of Retzius. And then to get that compression with those laparotomy pads, you're actually going to close your skin and close your fascia. Some people ask, well, how do you do this if you're actually going to do an X-lap? What if you also have, if you have like a really, like a grade 5 blunt injury of the liver that we need to get in control, in addition to a bad pelvic fracture where we suspect pretty bad hemorrhage? We essentially make 2 incisions and we don't connect them so that you can continue to get that compression in the pelvis. If you extend that incision all the way down, unfortunately, you've really lost that ability to effectively pack that space. So this is just something to consider, for our surgeon teams, thinking about if you're going to have to enter both cavities, try not to connect those fascial incisions. All right, so I kind of broke it up there with some discussion of pre-hospital and hospital care around pelvic fracture. Now I'm going to talk about resuscitation strategies. So first I'm going to talk about the broader principles of damage control. A lot of the research that's gone into that over the last 50 years and the guidelines that have come out. I think it's just important to realize where we are as trauma surgeons with this research. And then I will talk specifically about component therapy, whole blood, all of these things that I know you guys are always interested in. All right, so topics that we're going to touch on: permissive hypotension. What is it? Why do we do it? Why do we limit crystalloid resuscitation, rewarming? All of these kind of concepts are actually based off of US military practice in Iraq and Afghanistan. I'll go through a little bit of the history around this. I think I really like to understand where we're going. I like to know where we've been. I am not in the military. I've never been in the military, but I think it's really important for me to kind of understand like where the research is headed to understand, where the military research was and what we've learned from that. We are kind of this concept of, we always talk about airway breathing circulation, but now there's this big push with ATLS being updated once again. Version 11 just came out. I just took the course about a month ago. Um, Thinking really about the importance of circulation first. And so you really have to get your hemorrhage controlled because you're trying to do this limiting crystalloid resuscitation and you're trying to do permissive hypotension. So if those are your goals, then you have to make sure that hemorrhage is controlled. And so this is a really hot topic, thinking about where does hemorrhage control actually come into this. And I would argue that I think we're headed towards a CAB kind of algorithm. And then I'll talk about balanced resuscitation. All right. So when we think about the kind of different terms to just be aware of and different things that we need to think about. So warm, fresh whole blood, right? That's what they actually use in the military where they're getting fresh whole blood and giving it to another person. So when you ever hear that, that's what that means. There's cold whole blood. So that's actually what we use in the hospital. And so that stored whole blood has actually been processed. There's low titer O type whole blood, and I'll talk about that and why that's really important and somewhat controversial around childbearing females. Then there's component therapy. This is kind of like the chop shop. This is the one-to-one-to-one that we typically talk about. For if you're using just the different components, so if you're just using PRBCs alone, the universal donor is going to be type O, and then with FFP, universal donor is going to be type AB. All right. When thinking about blood, I'm sure you guys think about this as pre-hospital providers, really thinking about the shelf life of products, how they have to be stored. Very, very important to thinking about cost, storage, and access. So you've got your warm, fresh whole blood. The shelf life is short. And so that's kind of the big problem there. If it can be used quickly, it can be great. Our low titer O whole blood is going to be much longer. So 3 to 5 weeks, but it needs to be refrigerated. Packed red blood cells, a little bit longer to 6 weeks, need to be refrigerated. Platelets, much shorter. So these are the ones that they get on us for wasting. So 5 to 7 days, and are stored room temperature. That's how they come to us. And then FFP and cryo, these are often the ones that when we need them inpatient upstairs, we're being told that they're being thawed. So these are actually stored in a freezer, and the shelf life is much better, 1 year. So when you think about some of the studies I'm going to talk about, it's not just the curiosity around which one's better. A lot of it is around the cost. A lot of it's about the shelf life. If we knew that cryo and FFP from research are better, right, than warm, fresh whole blood, that would be amazing news for us because all we would really need is a freezer and it could be stored for 1 year. Unfortunately, that's not actually what we found. But this kind of the reason I'm going over this is because it does really matter because we're not just talking about hospital settings, we're talking about pre-hospital settings. All right. In terms of the composition of blood transfusions, and so here you've got your uh, volume right here of the additive solutions, the citrate phosphate dextrose solution. And so what's the actual total volume is going to be on the right side. Um, and this is really isn't super exciting here. All right, component therapy versus whole blood. So what's the deal here? So component therapy, you've got your PRBCs versus plasma versus platelets. And so if you're giving 1 unit of each of those, your total is going to be 660 milliliters compared to whole blood, which is going to be 450 milliliters. And you might ask yourself, why would I really care about that little difference of, milliliters? The reason is if you're talking about, I've had patients, unfortunately, get 100 to 150 units of product in my surgeries who are bleeding from their abdomen, their groin, and their chest. When that happens, this extra volume is actually pretty significant. And the reason being is that these people develop pulmonary edema and they go into essentially like a trolley ARDS picture and they end up on VV ECMO. So, if we had more access to whole blood, obviously we don't have access to 100 units of whole blood even in the hospital, but that would really cut down on the actual volume. And then if you compare the hematocrit of the products of component therapy versus whole blood, you can see that it has a whole blood has a higher hematocrit, has a much more significant number of platelets and coag factors. And so this is why there's really been this transition to whole blood. So in terms of military history, so World War I, we were really using uncross-matched whole blood transfusion. Spanish Civil War, there was this concept of a mobile whole blood bank. World War II, we're primarily using type O whole blood as primarily hemorrhagic shock resuscitation. And then in Korea and Vietnam Wars, we were using low titer type O whole blood in far forward environments. And then the global war on terrorism is where we really reintroduced whole blood across the system. And so it's this concept of, full circle. So in the 1980s, transfusion medicine really entered the mainstream with the advent of component therapy, and physicians began to specialize in administration of the individual products, so PRBCs, plasma platelets, rather than whole blood. And then this paradigm shift, driven by years of clinical experience, military practices, has shaped modern transfusion practices, transforming the way that all of our trauma patients are managed. So during wartime, trauma surgery advancements really provide invaluable lessons that later influence our civilian trauma care. And so the National Academies of Medicine have done a ton of studies on this, kind of balancing this bi-directional learning between military and civilian medicine. And these exchanges have led to innovations in transfusion protocols, our surgical techniques, resuscitation practices, all of this. And so, it's this kind of full circle coming back to this that I find incredibly interesting, that it's just this collection of massive volumes of really military research that has brought us back to whole blood. And now we have a dearth of data, unfortunately, in the civilian community around this. All right. So, why do we think what are the military advantages to using whole blood? Well, it's logistically easier, right? I went over refrigeration only versus needing a freezer. It's more concentrated. It has better oxygen carrying capacity, better plasma coagulation profile than FFP. They're cold platelets instead of warm platelets, so you get better coagulation, lower bacterial infection risk. And within the Iraq-Afghanistan conflicts, just to give you a sense of how well this was studied, they used greater than 10,000 units of warm, fresh whole blood in those conflicts. All right, transitioning a little bit. So here we've got the ATLS classification of hemorrhagic shock. This is one of the most important charts, I think. This is something that I really stress with our trainees in the trauma bay. So when thinking about the different classes of shock, it can guide you to think about how much blood do we think a patient has lost? Are they continuing to bleed? And are they progressing from one level of shock to another? And that's really going to guide decision making on where is the best place for them to be. Is the best place continued resuscitation in the trauma bay? Is it in the CT scanner? Doesn't sound like it. Or is it up in the OR? Usually it's going to be moving transfusions and up to the OR. So the big things to kind of take away from this chart are the following. So here we see that in class one hemorrhagic shock, you really are not seeing any abnormalities in the patient's vitals. So they can lose up to 15% of their blood volume and really not show you much of anything that's going on. It's class two shock, where you might even see a normal blood pressure. You start to see some tachycardia, but one of the most commonly asked questions of trauma attendings to the residents is, what is the most common thing you're going to see in the trauma bay that shows you that somebody's bleeding? And it's actually this decreased pulse pressure. So you can't just look at the blood pressure. You actually have to look at that systolic to diastolic and see if those numbers are kind of creeping together. That's very concerning. So we look for that decreased pulse pressure as our first sign. And then from there, you're going to see the typical class three shock. So the takeaway here is if you see a decreased blood pressure, meaning all of a sudden the patient has a decreased systolic, they've already lost 30 to 40% of their blood volume. All right. When we think about time to trauma death, I think this is important for pre-hospital providers to kind of get a sense. So, 50% of deaths are going to occur at the scene within minutes. And this is going to be a combination of terrible head injury that we probably could have done nothing for, unfortunately, in the hospital, and hemorrhage. And so, the reason that trauma surgeons harp on hemorrhage is because this is the only thing that we can fix. So, hemorrhage is up to 30 to 40%. Unfortunately, another 50% will die after hospital arrival. And you get 60% dying within 4 hours, 84% die within the first 12 hours, and 90% die within the first 24 hours. And then hemorrhage is going to account for 50% of deaths within the first 24 hours. So, this is the reason that we harp on hemorrhage. All right, shock index, we already kind of touched on, and then just to know what is normal and what is abnormal. So a normal shock index is going to be between 0.5 and 0.7. A shock index greater than 0.9 is most certainly a marker of injury severity and mortality. That's why I like to kind of think about this in the trauma bay, and I would encourage you guys to start calculating this out in the field and see if you feel like it's actually a good estimate. I think that's kind of an interesting thing to do. Caution in geriatric patients, this may actually underestimate shock due to higher baseline systolic blood pressure. Also, just remember with these geriatric patients, one of the most commonly missed things that we see is that patients are on beta blockade. And so we think that they're not tachycardic, but it's just masked and they're actually bleeding. And we've talked about the, pre-hospital use and triage for shock index, as well as predicting risk for mass transfusion. Our shock index does not actually trigger mass transfusion event, but you could certainly use that. All right. What are confounding factors in response to hemorrhage? So why do people respond differently? It could be patient's age. So you have to think about their systemic vascular resistance. That's really important when thinking about how well people are going to hold blood. Additionally, at different ages, right, we're going to have different competency of our venous valves. Pre-existing diseases and medications like beta blockade, severity of injury, access to care, the duration of shock, and the amount of pre-hospital fluid the patients got, which can cause hemodilution, unfortunately, and then the presence of hypothermia. So all of these things can actually, you might think that you're resuscitating a patient appropriately, but if they're hypothermic, we encounter this often in the OR. We just don't understand. They're just like hosing blood. We're giving them blood and they are still not well. And then I ask what the temperature of the patient is. It's 33 and the room is not warmed up. So we try to get the bear hugger on and get them warmed up as soon as possible, because it doesn't matter how much blood you give them if they're coagulopathic. And quite honestly, it's probably too late at that point. Some IV access principles in shock. I think these are important for pre-hospital providers. So, antecubital fossa is going to be your fastest, simplest route, and it's going to be the best. We want large bore, short length, so 14 to 16 gauge. That's going to be kind of when we say like large bore IVs, that's what we're referring to. Flow is going to be limited by IV gauge and length, but not the size of the vein. So, in terms of kind of like national guidelines, this is consideration as optimal treatment. Two people attempting simultaneously during transport. If you're trying to get central access, you might be trying two different sites above and below the diaphragm. One patient population I really think about with this is like a very pregnant patient, right? So if they are 36 weeks pregnant and we're worried that they're bleeding and you put their central line in the groin, it's really not going to do much, right? Because they've got decreased return, venous return, because of the IVC compression. So you want to put them in left lateral, but you also want to be making sure that you're trying to get your access in the arms. So think about their injuries. Think about where you think the blood, if they're bleeding, where is the blood going? Don't put access distal to that because it's not going to help. They're literally just going to bleed into their abdominal cavity or in their chest. We want 2 to 3 sites. Two is probably sufficient. And then we think about peripheral IV. And then obviously we also have IO in here, depending on your protocol. Ours, I believe, is I think we get 90 seconds to IO if peripherals aren't working. And then I'm a big fan of just going for femoral access, especially in a very hypotensive patient, or doing a cut down and doing like a saphenous vein cut down, because there's nothing more important than giving a bleeding patient blood. All right, damage control resuscitation. So what is that? So this is a great paper that really just describes the core principles. This is East is one of our big trauma associations. There's the Eastern Society, Western Society. So this was a study that came out in 2017, kind of like a systematic review telling the trauma community what we mean by these principles. So, damage control resuscitation, it is a systematic approach aimed at minimizing blood loss and correcting coagulopathy in severely injured trauma patients. The core principles are going to be permissive hypotension, which means maintaining lower blood pressure targets to reduce bleeding until surgical control is achieved. We're going to limit our crystalloid use by limiting traditional IV fluids. We're hoping to prevent dilutional coagulopathy and tissue edema. We want to do a balanced blood product transfusion, so early admin of blood products and ratios that mimic whole blood to address both oxygen delivery and coagulation needs. And then I would argue that, this will probably get updated and say just give whole blood. And so this is just a little bit, I'm going to skip through this here. And so here we go. The main things we have to have early recognition. And so really thinking about that shock table, thinking about pulse pressure, not just the typical ones of an increased heart rate. I promise you, if you start paying attention to this, you're going to actually really realize that it's the first sign of a vital sign change with hemorrhage. And then this is very important, right? Protocol development. So what are you doing in the field? What is your go-to? Are you using whole blood component therapy? Kind of understanding what you have access to and what you should be giving first. Protocol developments even within the trauma bay and what we're doing within the hospital and how we work with blood bank. And then of course, multidisciplinary approach. So we've got so many different types of physicians touching these very sick trauma patients. And so just making sure that we have a coordinated plan on how we are going to appropriately resuscitate these patients. And I'd say within our system, everybody's really on board on, blood first, permissive hypotension, all of these kind of strategies. All right. So in terms of whole blood resuscitation, so this was a systematic review. This was also an East study, and became a practice management guideline. These are the go-tos for trauma surgeons. These are the things that we read. So I highly recommend if you're looking for more data, more information, you kind of want to see what's up to date. East is a great place to read current guidelines on what the trauma community is kind of thinking. So this guideline's from 2024, and essentially it was kind of figuring out what is this reemergence of whole blood resuscitation? What does it mean for the trauma community? So, recent interest has grown using whole blood for trauma resuscitation, aiming to improve hemostatic capacity and reduce transfusion volumes. Because unfortunately, even with component therapy and one-to-one, hemorrhage is still the number one cause of death amongst trauma patients once they're in the like pre-hospital and then once they're in the hospital. So, this study was evaluating the efficacy of whole blood compared to component therapy. This was in adult civilian trauma patients requiring transfusion. They did a systematic review and meta-analysis. Effectively, they looked for every single study that had ever been written on this and tried to summarize the findings. So their key findings, they found that in terms of mortality, there was one randomized clinical trial that indicated a survival benefit with whole blood resuscitation. When thinking about transfusion requirements, whole blood resuscitation was associated with reduced early and 24-hour transfusion volumes. However, this is the key point, quality of evidence, this was in 2024, the overall quality of evidence was rated as very low, highlighting the need for further research. So their recommendation here, it was a conditional recommendation that they conditionally recommend the use of whole blood in the acute resuscitation phase when it's available. And then after the initial resuscitation, an individualized goal-directed transfusion approach is advised. This is exactly what we're doing at the University of Colorado. So we go through our whole blood, whatever products we have. If we really believe that someone is bleeding to death, we will use all of the whole blood that we have. And then as soon as we get to the operating room, if we need more blood and we don't have whole blood left, we go ahead and we ask the anesthesia team to make sure they're getting TEGs. And we do, when they say goal directed, that usually means TEG-based resuscitation. So we're not just blindly giving one-to-one. We actually start with one-to-one, and then we get TEGs throughout our case. And then typically we're doing that in the ICU for as long as we think they're coagulopathic, which can really depend on the patient. And there are different reasons for why they might be coagulopathic. So the theme of this evening is additional high quality studies are needed. So this is the hot topic. So if anyone wants to study this, this is a big area of research right now in thinking about whole blood use in civilian populations. I'm not going to really talk about this, but this is a study that I checked tonight. I still didn't see that the results have been published. But just to give you a sense of how important this is a huge first large-scale randomized controlled trial. This is actually just the protocol study telling the trauma community how they're going to do their study, but they don't have the results yet. And so they were targeting recruitment of 848 participants in the United Kingdom, looking at multiple air ambulance services and trying to really look at the pre-hospital. So think about this SWIFT trial and kind of look out for that in the future and those results. It's going to be important to what you guys do. This is another paper here. This was JAMA 2023, looking at evaluating the survival benefits of whole blood as part of an MTP protocol compared to component therapy. This was looking at level 1 and level 2 trauma centers from 2017 to 2018, retrospective study using the TQIP database. And they found that whole blood reduced mortality by 37% at 24 hours and 47% at 30 days. And really no significant increase in major complications, although whole blood recipients had a slightly longer hospital stay. I can tell you that might be, if someone's really sick, I am much more, the protocols are really leaning towards using whole blood in patients that we think are in true hemorrhagic shock. Versus someone who I think has a little bit of soft blood pressure with blunt traumatic injury. I put my pelvic binder on and I might give them some component therapy. And so it's really kind of up to the trauma surgeon about how we use resources. But that could be, it might be that sicker patients are actually getting whole blood. So you kind of have to think about why that might be the finding there. So their conclusion here, whole blood, massive transfusion protocol actually improves survival in civilian trauma patients with severe hemorrhage. All right, so how do we remove the barriers to pre-hospital blood? This is a great paper. This came out in 2024. It's kind of more of a policy paper. But it's really talking about like how do you actually like what are the barriers to these systems and how can you set it up? So I'll kind of give you the main takeaways here. So less than 1% of EMS agencies around the nation actually implement pre-hospital blood transfusion. So this is very rare. Um, they started doing it actually when I was a fellow at Shock Trauma. One of my friends who was a co-fellow of mine at Shock is now really integrated into the pre-hospital system down at Emory, at Grady, another big trauma center. And this is the first year that they are getting pre-hospital whole blood transfusion. Um, so the barriers, as you can imagine, are going to be scope of practice questions, costs, lack of data systems, limited collaboration. Texas and Florida are actually leading implementation due to flexible medical oversight models. So often at trauma conferences, they talk about these two states and kind of what they've been able to do. Program costs can exceed $1,000 per patient and often not reimbursed. There's a lack of a national registry to actually track outcomes. That's a huge problem when you're trying to look for funding if you don't have the data to prove it works. These collaborative models with blood banks and hospitals really improve sustainability of these kind of programs that get started. Obviously, once again, rural underserved areas are going to be at higher risk due to limited access and funding. Um, these can be really vital in mass, MCI events, disasters. And so they're really talking about what this national roadmap will look like. And so thinking about not just pre-hospital component therapy, but even whole blood, like what is this going to look like? So as you guys can tell, this paper came out in 2024. Very, very hot topic. All right, I am going to quickly talk about whole blood and pregnancy here. So I'm going to skip over this. This is about alloimmunization, right? And so these are kind of the basic tests that we need to do. This is more going to be on the inpatient side, so I wouldn't worry too much about this. But just to kind of understand the controversy here, I think you have to understand the basic science behind alloimmunization. So alloimmunization occurs when you've got an Rhd negative, like a Rho negative individual developing antibodies against Rho positive blood, which can lead to hemolytic disease of the fetus and newborn and future pregnancies. And so centers like ours, where our trauma patients actually might be getting their OB care, often we actually have their status even before we even do any kind of blood test, and we kind of know what their status is. Um, there is a limited Rho negative, low titer O whole blood supply. So only 7% of North American blood donors are O Rho negative, leading to a reliance on Rho positive blood for trauma resuscitation. So when we talk about the risk perception, and this is the big controversy here, while the likelihood of alloimmunization leading to adverse outcomes in future pregnancies is low, as low as 6.5% at age 18, decreasing with age, this potential risk often deters its use in childbearing age females. So, but we know we've already gone over some of these studies that we think that low titer O whole blood is associated with reduced mortality. Um, Surveys actually indicate that most women would prioritize their own survival over the small potential risk of future fetal harm from alloimmunization. And then this study really looked at practice variability across trauma centers and found that there's a huge lack of consistent policies amongst blood banks and trauma centers regarding the product selection for childbearing age females. And some institutions are actually going to prioritize the Rho negative low titer whole blood, while others are going to use the positive based on inventory or urgency. And so it really depends kind of on your hospital system and how much negative blood that they would have. But a lot of women trauma surgeons and women trauma researchers are starting to advocate most women would actually just accept this risk. So why is it not just policy to give them if there is whole blood available, even if it's positive, titer positive, that they would go ahead and give that. All right. We're gonna skip through plasma resuscitation here. And I'm going to end with pre-hospital TXA and a little bit of more kind of pregnancy stuff. So this is a big one. This is 2023 Patch Trauma Investigators and the ANZIX Clinical Trials Group. So they wanted to evaluate whether pre-hospital admin of TXA improves survival with favorable functional outcomes at 6 months in patients with major trauma and suspected coagulopathy. Their primary outcome was no significant improvement in survival with favorable functional outcomes. So 53.7 versus 53.5% with placebo. For secondary outcomes, they found that it reduced early mortality, 9.7 versus 14.1% at 24 hours, and reduced 28 day mortality, 17.3 versus 21.8%, but not sustained at 6 months. They did not find any significant increase in thrombotic complications or adverse events. This is something that's commonly cited as a problem with TXA. And so their conclusion here was while TXA reduces early mortality, does not improve long-term functional outcomes in patients treated in advanced trauma systems. So once again, further research is needed to identify subgroups that might benefit. So it completely depends on your trauma system, your state, kind of what's going on. There are trauma surgeons who believe in it, trauma surgeons who don't believe in it. We have a trauma conference at the University of Maryland that's called Point Counterpoint, and almost every year TXA is one of these things. I took this slide. I also give a talk on trauma and pregnancy for pre-hospital providers. So I took this from that talk. In terms of the guidelines around pregnant women, I would say that TXA should be used. So 1 gram of TXA as soon as possible after injury, but no later than 3 hours. You just have to remember pregnant women have a huge amount of blood volume. And so these are very, very vulnerable trauma patients. In terms of evidence around this, because I'm a big fan of evidence, so you guys know where things are actually coming from. The woman trial in 2017 that was examining the use of TXA in postpartum hemorrhage, not trauma specifically, found a significant decrease in death. And then again, the CRASH 2 trial. This was a big study. This is one of the most popular trauma studies that we talk about with TXA. Looked at 20,000 polytrauma patients, showed that IV TXA given within 3 hours of injury reduces death due to bleeding and all-cause mortality. So people who are proponents of TXA are usually talking about the CRASH 2 trial. And so that's where some of these guidelines, in addition to the woman trial, come is the CRASH 2 trial. Current ATLS guidelines recommend TXA administration for within 3 hours of injury in adult trauma patients with class 3 or 4 hemorrhage, requiring MTP or evidence of fibrinolysis on coagulation testing. Basically, if you're bleeding, ATLS wants you to get it. So, given the primary tenet regarding the management of pregnant trauma patient continues to emphasize maternal resuscitation, literature suggests that TXA should be provided to pregnant patients. So that's one patient population that, in my mind, there's really not a good debate. I think we should give it. All right, and we're going to end with pre-hospital tourniquets. Once again, this is how you guys save lives. I can't tell you how many patients' lives have been placed by have been saved by tourniquets that had really severe hemorrhage that if EMS had not, pre-hospital providers had not put a tourniquet on in the field, they would not have survived. But it's an important question, right? Because I can tell you as a resident, when I was like a first year resident, this was actually kind of still controversial if tourniquets were good. And so they studied it. So in 2018, they wanted to look at the impact of tourniquet use on survival rates in civilian trauma patients with peripheral vascular injuries. So they had a lot of military data to show that it worked, but they didn't have a ton of civilian data. So this is the whole blood kind of use question all over again. This was actually done with tourniquets quite a while ago. And so they found that tourniquet use resulted in a six-fold reduction in mortality. They found that there was no significant increase in delayed amputation rates or complications. So you really think about thromboembolic events with the use of tourniquets. You also think about the fact that when you put a tourniquet on, you're actually delaying blood flow. So although they aren't bleeding out, they're actually not getting blood down to their extremity. And so you do worry about the use of tourniquets and delayed amputation rates. This is why it's really, really important for you guys to let us know when you come in the door how long it's been on. I'm much more willing to take somebody quickly to the operating room If I'm having to triage different patients, I'm obviously going to try to get this patient up to the OR if you tell me that the tourniquet's been on for 2 hours. Mortality decreased from 5.2% in the non-tourniquet group to 3.9% in the tourniquet group. And so this study concluded that the civilian pre-hospital tourniquet application is associated with significant survival benefits, supports more aggressive use in extremity hemorrhage cases. And so further education and resources are recommended to expand adoption. I love that they didn't say do more studies. They just said, let's educate and let's do, further resources for the community on tourniquet placement. And so that's what happened, right? So if I can leave you guys with anything today, that advice I can give, two life-changing goals here. One, stop the bleed, save the life. So this is the resource that was developed by the American College of Surgeons. And it's this concept that if you can actually stop bleeding, and either through the use of a tourniquet, compression, thinking about where you're actually putting your access in relation to an injury so that they get blood products, all extremely, extremely important, because I might be able to stop the bleeding once they get there, but if they are already coagulopathic and they've kind of gone into that spiral, unfortunately, there's not a lot we can do if they're under resuscitated and extremely coagulopathic and cold. So stop the bleed. And then obviously the big point of this conversation was talking about whole blood resuscitation. And so I think whole blood resuscitation is most likely the future of the resuscitation of a trauma patient. I think we're going to see a lot of research coming out in the next 5 to 10 years, guidelines changing. And I'm just really excited and proud to be in a system that really uh, understands the importance of whole blood. And I feel like, I can get it for when I need it for my patients. So, two big things that I think are key for pre-hospital providers. All right, so I'm going to stop sharing my screen. If you guys have any questions ever about anything trauma related, please feel free to reach out to me. My email's pretty easy, christy.hawley@cuanschutz.edu. And we've got about 14 minutes for questions if anyone has any.
Thank you so much. Are you able to see the chat? Otherwise, I can read the question in there.
Oh, yeah. Is it better to place a tourniquet closer to the wound or have it high and tight? I would say, quite honestly, wherever you can get the best control, is probably going to be the best answer. But if you can get control closer to the wound, I would do closer to the wound, because the reason being you have so much kind of like venous circulation, and alternative paths that are not in the major arterial highways. So it can really help prevent a compartment syndrome. So that's why I try to keep mine lower. And I'm going to put my email here in the chat, right? Oh, perfect. You got it. Thanks, Laura.
And I'm going to put up the QR code so everyone can get credit. I thank you so much. That was awesome, especially the pelvic binder stuff, which I obviously am very invested in that as well. So thank you so much. And then I'm pretty sure all the agents, so there's only a couple agencies in Colorado that carry whole blood pre-hospital. It's sort of new and starting. But I'm pretty sure I'm going to have a bunch of agencies now ask me how we can get whole blood. So thank you for that. And yes, I will make sure to put the link in the chat as well, Stacy.